Menarini Foundation has been a very spectacular idea to improve all of our knowledge about the pharmacology and the clinical medicine.
Fondazione Menarini is a unique organization with no commercial bias, no commercial interest. It is putting together some of the best learning events in the country, outside the country, worldwide.
Opportunities abound, and the fastest economic growth achieved is also witnessing the fastest growth in the healthcare sector, which is why we've established our presence and positioned ourselves as the partner of choice to bring important healthcare brands across the region. Menarini Asia Pacific. As part of a leading global biopharmaceutical company, Menarini Asia Pacific's capabilities span the entire pharmaceutical development life cycle. A fully integrated biopharmaceutical company capable of research, development, manufacturing, regulatory affairs, and commercialization. Beyond end-to-end capabilities and cross-functional expertise, Menarini Asia Pacific has also become the preferred partner for leading healthcare companies around the world. Our expertise in building healthcare brands, flexible business model, and dedicated alliance management to create value for our partners have enabled us to make strategic acquisitions and licensing arrangements, consequently taking many brands to greater heights. Our rapidly growing businesses are bolstered by over 3,300 sales, marketing and support professionals operating in 13 key markets. Our sales and marketing strategies, underpinned by local patient and physician insights, have helped many companies with varying needs tap into the Asia-Pacific growth story. Whether for new brands or line extensions, pharmaceutical or biotechnology companies can gain rapid market access to the region and manage their risks by leveraging on our strengths as a gateway to Asia Pacific, a reliable partner whose network and reach extends beyond the region, with a strong track record offering unparalleled customer experience. Founded in 1886, the name Menarini has through the generations become synonymous with the mark of quality. A trusted biopharmaceutical company with a strong tradition in partnering, an established presence in over 100 countries with more than 16,000 employees, Menarini is bringing its illustrious heritage and compelling values into the next century. And here in Asia Pacific, our ongoing commitment is to deliver quality healthcare brands, invigorating lives across the region. Your partner, your brand, at your service. Menarini Asia Pacific.
O Holy Spirit, we thank you for the advancements that have led to improving the health of so many. We beg you to inspire new breakthroughs in overcoming the coronavirus and all serious flu viruses. Protect, we pray, healthcare professionals from the illnesses they are treating and make them instruments of your healing. Amen.
Good morning, everyone, and welcome to today's PCR Connect webinar, brought to you by the Philippine College of Radiology and sponsored by Menarini Philippines. So before we go to the agenda, I'd first like to lay down the house rules. So all audio will be on mute, and if you would like to answer or ask a question, you can type it at the Q&A chat box below. We do encourage everyone to please take time to answer the feedback form at the end of this session to improve future webinars. So now we go to the agenda. So today's agenda will be composed of 2 lectures. Our first lecture would be about the emerging and re-emerging infectious disease preparedness of the radiology department in RITM, to be discussed by Dr. Myla Macababal. Our second lecture would be the workflow in radiology department in the setting of COVID pandemic, which will be discussed by Dr. Mark James de los Santos. And of course, our Q&A will be moderated by Dr. Emerzen Alepanyo. So just to introduce our moderator, Dr. Alepanyo is currently the Secretary of the Philippine College of Radiology. He is likewise a CT scan and section head at the UP PGH. In addition to that, he's assistant chairman at the Asian Hospital and Medical Center, and a CT and MRI section head also at the same institution. So to give us some words on the PCR Connect, I call on Dr. Imar. Dr. Imar, you have the floor.
Yes, thank you, Dr. Gabby. Hello and good morning. The PCR would like to welcome you to the first of a series of lecture under PCR Connect. The objectives of this platform is to enhance communication among members and trainees and disseminate informations to improve the practice of radiology, especially in this fight against COVID-19 pandemic. So sit back, relax, and happy learning. Back to you, Dr. Gabby.
Thank you, Dr. Imar. So now we go to our first lecture. So our first lecture will be discussed by Dr. Myla Macababal. So Dr. Myla is currently the Medical Specialist 3 of RITM. She is a fellow of the Philippine College of Radiology, CT MRI Society of the Philippines, and Ultrasound Society of the Philippines. She's likewise the Department Head, Diagnostic Imaging Department of RITM. She has a Master's in Hospital Administration and is the President of Diels, Apiary, and Meadery Incorporated. Now to discuss emerging and re-emerging infectious disease preparedness of the radiology department in RITM, I give the floor to Dr. Myla Macababal.
Hi, good morning, colleagues and friends. This morning, I am going to share with you how our diagnostic imaging department in RITM has been preparing for new or emerging and re-emerging infectious diseases. First, a brief history. The Research Institute for Tropical Medicine, or RITM, is one of the country's infectious disease center under DOH. Established in 1981 under a grant-in-aid agreement with Japan International Cooperation Agency, or JICA. If you will remember, Japanese government donated the first COVID test kits in the Philippines to RITM earlier in this pandemic. The institution's mission is to protect the Filipinos against infectious diseases through the conduct of the globally competitive research, training, clinical and diagnostic services, and production of biologicals. The hospital has 50 beds for infectious disease patients only. We do not perform major surgical procedures, but we do have tracheostomy and chest tube insertions and simple drainage procedures. We are one of the outbreak responders in the country, and PPEs of level 4 protection is always available. In the diagnostic imaging department, so far we only have X-ray and ultrasound machines. We are to procure CT scan probably next quarter. Then let me show you the institution's operational code for emerging infectious diseases, or EIDs. Okay, this is separate from the country's pandemic or outbreak coding system. All of RITM sections, including nursing, laboratory sections, and even dietary, have different activities in all codes. All activities are activated at the same time when a code is called. But I listed here only the radiology department's activities. Our operation is paralleled with the general situation in RITM based on the number of admission of a particular disease in question, which is COVID-19 in the present case. So up to 6 number of admissions, our department's operation is normal. More than 6 admissions, we have an on-call or standby staff in case of sudden surge. Codes blue and red, we already have a template of the schedule for 2 shifts, 12-hour duties, straight 3 days, that we will just fill in with names. Okay. Rad techs with comorbidities like hypertension, diabetes, and others will be assigned as support tech in the body system. We are on code red if one whole wing is full of EIDs and we are unable to transfer EID cases to other hospitals in the setting of widespread community transmission. Our OPD is closed. We admit EID cases only, and we are closed for all other infectious disease cases. We put our X-ray and ultrasound machines in the wards. Okay, and another 1 portable X-ray machine in triage. In the past, Code White 2 was carried out for SARS in 2003. Then in 2009 was Ebola of West Africa. We had very extensive infection control training here. Okay, we had only 5 cases in the country then, and fortunately we had the non-deadly resistant strain, so patients did not require quarantine or hospitalization. So our code then was green with normal operations. Wait, a little bit of trivia. Do you know that the first hospital-based transmission case of SARS in 2003 involved a radiologic technologist where the index case was admitted, which is not in RITM. Then came MERS in 2015, which also reached code White 2 in RITM. And so far, up to now, no RITM RADTech has been infected through patient care. In general, of course, we have to boost our immune system, and RITM provides us with free vaccinations, including annual flu vaccines, pneumococcal vaccines, even pre-exposure anti-rabies, and whatever vaccines applicable. They also provide us with the annual or as-needed infection control training and retraining from hand hygiene, risk assessment and management, even waste disposal, for all employees from receptionists, orderlies, up to the directors. Then, annual fit testing, okay, for N and P series of respirators, and retraining or as needed for new respirators made available. Next slide. Okay, so question. Is any one of you familiar with fit testing? 5 seconds. Okay, what is fit testing? It is a method to detect leakage into the respirator. It is required by the Occupational Safety and Health Administration, or OSHA, to do initial fit testing to identify the right model, style, and size of the respirator for each worker. There are actually two methods, the quantitative and the qualitative. What we use is the qualitative fit testing, which uses the sense of smell or taste. A hood is placed over our head and a chemical is sprayed through a hole. If the worker tastes the bitter chemical, then the mask is not for you. Then another mask or model is put on until you get the right fit. Then we are asked to do aloud reading, simple activities like head turning, and more vigorous activities like running and exercising with chemical sprays in between to make sure that we are effectively protected by the mask when performing our duties. Okay. Then when you have your right model and size, we do seal check every time we use that specific mask to check if it is properly worn. Seal check is done by cupping your hands over the respirator and exhaling sharply. Okay. If the air leaks around the nose, adjust the nose piece, and if the air leaks at the sides, adjust the straps. So it is not enough to say that you are wearing, example, the N95. It must properly fit and worn. There are other masks and respirator that doesn't need to be fit tested. There are so many things about masks and respirators, and we will need a separate one whole lecture for that. There are many YouTube videos on how fit testing and seal checks are done properly, so you may want to check them out later. On final thought on fit testing, do not confuse a fit test with a seal check. A fit test is a method used to select the right size of the respirator for the user. The seal check is a method to verify that the user has correctly put on the respirator and adjusted it to fit properly. A seal check must be performed each time an employee dons a tight-fitting respirator. For our department's normal operation, OPD patients are serviced 8 a.m. to 5 p.m., overlapped with shifting staff schedule with single duty at night, weekends, and holidays to serve inpatients. Okay, we do all portable procedures to all inpatients. We do not want them spreading their infections in the hallways and OPD areas. But of course, our operations is made easier and safer with good engineering structure, having good exhaust system, and windows. Yes, we have windows in all our diagnostic areas to help with air exchanges. We need at least 12 air exchanges per hour. We have identified donning and doffing areas. And operations, of course, are interfaced with other departments. Good communication is the key. We have all year-round triaging for OPD and ER. They are already given out complementary masks for symptomatic patients, for patients with cough and cold, so that when they go inside the facility, masks give some security for the employees. And most importantly, diagnosis and special precaution are already indicated in the request forms. If no precaution written, then it is just the standard precaution. For a standard precaution, of course, the hand hygiene, which can be hand washing or alcohol-based hand rub. But always remember that hand washing is better than hand rub. Our infection control does random visits in all departments and directly observes the performance of duty and checks if hand hygiene is properly done. They even check our waste if they are properly segregated. Then you have the cough etiquette. Disinfection of equipment is done daily by our RADTEC staff. Disinfection of cassettes and frequently touched surfaces like the chin rest, controls, rotor buttons, VCH, tube handles are done. by our RadTech staff every after patient. Room cleaning is done by housekeeping. Linen in ultrasound is also changed by RadTech staff every after patient. For PPEs, we always wear surgical mask. Gloves and gowns are worn depending on the anticipated exposure. We use bleach-based disinfecting wipes for disinfection. And of course, they always wear gloves when disinfecting. We are very conscious about the transmission-based precautions. There are 3: contact, droplet, and airborne precautions. Required for contact precautions are gowns and gloves, surgical mask and face shield for droplet precautions, and fit-tested N95 or P100 is a must for airborne precaution. Patients with airborne precaution are placed in negative pressure rooms. We also have to be familiar with the diseases with the special precautions. For contact precaution, those with draining wounds like your methicillin-resistant Staph aureus, rashes, and uncontrollable diarrhea like your vancomycin-resistant enterococcus. Examples of your droplet precaution diseases includes flu, whooping cough, and mumps. Okay, TB and varicella are examples under airborne precaution. Another question. Measles is an infectious disease that would require droplet precautions. True or false? Answer is false. Okay. Measles, together with TB and varicella, requires airborne precautions, not droplet precaution. There are also special doffing steps to remember depending on the precautions. For contact precautions, discard masks and gowns before leaving the room. For droplet precautions, discard mask and eye protection upon leaving the room. And for airborne precaution, mask is discarded outside the room and after closing the door. Okay. Another question. Ebola disease requires contact precaution. True or false? The answer is true. Almost all bodily fluids in Ebola is infectious. Vomitus, diarrhea fluids, urine, saliva, etc. I mention this because Congo is now faced with new epidemic of Ebola. So let us pray harder that it will not become a pandemic because it has a higher fatality rate than SARS and COVID. Donning and doffing have special sequence to follow depending on the precaution. In donning, it is very important that you start with hand hygiene. And basically in doffing, almost every step is followed by hand hygiene. Sequences will depend on the additional PPEs worn, like if you have additional shoe cover and head caps or aprons and boots, we take off the shoe covers first, then head cap and goes with the eye and mask, okay, and coverall is considered a gown. Incorporating our X-ray portable procedure, here is our sequence. Okay, we double bag our cassettes and don double gloves before bringing the cassettes to the wards. We don't anymore put plastic on the portable X-ray machine itself. That is for Ebola. but we put plastic on ultrasound controls and probes because they are placed closer to the patients. Then after the X-ray or ultrasound procedure, okay, while inside the room, we take off the outer gloves together with the outer plastic of the cassette, followed by hand hygiene. Then disinfection of the frequently touched surfaces, your control panel, your handles, rotor button, and the cassette. And then portable X-ray is pushed out of the room into the hot zone where the disinfection is completed, followed by another hand hygiene. Then cassette is handed over to the support rad tech, or if you are on single duty, you place the cassette in a receptacle to be collected after donning of PPEs. Okay, then the rad tech proceeds to the doping area for completion of the rest of the donning of the PPEs. I am going to play a very short video which was uploaded earlier in this pandemic on how we bag our cassettes for infection control. Okay, so that demonstration is better than just a list of steps. Okay, for new and emerging infectious diseases like now with COVID, we use level 4 PPEs initially, since we still don't know how the organism behaves. And then we have hired additional RadTech staff and set everyone for training to be an observer. Okay, the role of the trained observer is to observe only one healthcare worker at a time from the time they enter a patient's environment to the time they exit. So this is one-on-one. So the RadTech guides co-RadTech or observes co-RadTech. A checklist is filled up for every step of donning and doping, disinfection, and in the performance of these 5 moments. So before patient contact, before clean or aseptic procedure, after blood or body fluid exposure risk, after patient contact, and after contact with the patient's surroundings. At any time, if there is any breach in any of these steps, you may be asked to repeat a step or worse, step out and change into new sets of PPEs. So for RadTech, okay, hand hygiene is a must before and after contact, patient contact, and contact with patient's surroundings. Previously, only nurses served as trained observer, but in this pandemic scale, where nurses are too busy and becomes too few in number, RadTechs will observe RadTech. So we needed additional staff for 3 duties every 12 hours. One is assigned as a trained observer. Okay, now after gathering data and learning from the experiences, uh, own experiences and other countries' experiences, we are ready to downgrade the level of PPE use. For procedures that does not produce aerosol, which includes our X-ray and ultrasound procedures, the preferred PPEs now are just isolation gown, N95 or surgical mask with face shield, and of course gloves. So coveralls, shoe covers, and head caps are no longer required. If you are going to extend the use of N95, be sure to perform hand hygiene before and after touching the respirator. Okay, I think that is my last slide. So actually for our ITM diagnostic imaging department, there will be no significant change for the new normal, except probably for the very difficult to maintain social distancing. Okay, thank you, and I hope you have picked up some things that you can use in your practice.
Thank you very much, Dr. Makababad, for the lecture. So before we go on to our next discussion or our next lecture, I'd like to remind everyone that you can type your questions in the Q&A chat box below. So now we go to our next lecture. So our next lecture, which will be presented by Dr. Mark James de los Santos. So Dr. de los Santos is currently a fellow of the Philippine College of Radiology and CT MRI Society of the Philippines. He's also a treasurer, secretary, board member at Image Diagnostic Radiology Consultants, board of director at the Philippine College of Radiology. He's the chair, Residency Training Council of the Philippine College of Radiology. He's also the department chair of QualiMed Hospital Alcaraza and PNP Diagnostic Center. He's likewise a consultant staff of QualiMed Manila and Mediscan Diagnostics Center, and a council member of the Health Technology Assessment Council. So now I turn the floor over to Dr. Mark James de los Santos. Dr. Mark, you have the floor.
Thank you, Dr. Gabby. Just want to ask first if my slide is being seen.
Yes,
Are
Doc,
you
it's
hearing
clear.
me?
It's clear, Doc.
Okay. First and foremost, I would like to thank Menarini for sponsoring this activity for the Philippine College of Radiology. I'd also like to place special appreciation to Dr. Emerson Elapanio, who asked or probably coerced me to actually do this so I can say no to him. So I did this lecture, which is the new normal workflow in the Department of Radiology during the COVID pandemic times. We have been facing with this what we call the new normal workflow in the Department of Radiology, and it's quite different from what we usually had prior. So as a disclaimer, this is based on the interim guideline that was released by the Board of Directors of the PCR last May of 2020. And this is still in constant evolution based, of course, on upcoming evidences. So we already had the version 2, and later on, most likely with upcoming evidences, we might be coming up with other versions of this. Likewise, I will probably put another disclaimer for me and Dr. Ramayla Makababad. We are not infectious disease control experts, but we will be doing our best to be able to answer your queries based on the international and local guidelines that we have sought for this particular lectures that we've made for all of you. So all of us have been used to what's called the new normal and what's called the old normal. Probably it will be a great adjustment for all of us. If prior to this, you are actually you are getting used to having your exercises together with other people, enjoying the hardships together with other people, then probably with the new normal, you have to endure all the hardships on your own. Likewise, if you have been used to the old glamorous radiologists, the likes of Dr. Luz Tamayo or Dr. Cynthia Magsino Uy or Dr. Irma Quintanar or even Dr. Silva, showing to you this look complete with a signature bag containing their gadgets and all, You might actually be seeing them wearing this in the Department of Radiology, holding a garbage bag, most likely containing their own clothes. If we have been used to the usual old convention, our glamorous and fabulous conventions that we have, and enjoy the feast that is being given to us for every time during lunch symposium, then we will be having to be confined with the new normal of having webinars for our own protection and probably enjoy your own pandesal or own chichirya, probably while listening to the lectures. So this is very important for us to really get familiarized and adjust with what's called the new normal. And for us to be able to achieve this, we have to follow a certain workflow or protocol so that we will get used to it. The general objective of this lecture is to observe the general principles of infection control, to actually give us a patient flow prior to the entrance to the Department of the Radiology and the Department of Radiation Oncology. Likewise, the patient flow and handling within the department, the patient flow and handling for suspect, probable, or even confirmed COVID-19 cases. We will be giving to you additional principles, of course, in handling patients within the Department of Radiation Oncology. And of course, very important, I think, is the disposition of our staff who rendered services to suspect, probable, or even confirmed COVID-19 cases. So in general, what is a workflow? In general, a workflow is the sequence of industrial, administrative, or even other processes to reach a piece of work process from initiation to completion. It's very important for us because it will help us streamline and automate repeatable tasks to minimize, of course, room for errors and increasing overall efficiency. Thus, in turn, for our benefit, it will dramatically improve infection control. Likewise here, the manager can can make quicker, even smarter decisions, and their employees are empowered to even collaborate in a more productive and agile way. Likewise, having a nice workflow will simplify the operation, would eliminate unnecessary movements. We can combine two operations into one where possible, or even improve old methods. So what is the aim of the PCR workflow? Generally, the aim of the PCR workflow is to give its members, both in hospital and a clinic setup, to be able to have a condition or a guideline wherein you can follow. Of course, this is just a workflow that is recommended. Your own institution can actually adjust to this particular workflow depending on the advice of your infection control experts, especially in your own institutions. First is to be able for us to be provided an ideal setup for the radiology department in its daily activities, while of course maintaining infection control. Likewise, the workflow can guide the radiology staff in the daily provision of services. It can also elucidate a proper patient flow in the department following rules and regulations set by the Bayanihan Act. And most important of all is to maintain the safety and health security of the radiology department staff. In general, principles for infection control for all ordinary, either suspected or probable or confirmed case of COVID-19 virus or disease, triaging or screening of patients is the first step together with their visitors. They must be checked on all entrances of the hospitals or clinics before they can proceed to the reception area of the department and even in the examination areas. This will also include triaging, of course, of the patient companion and will also be in provision for all outpatient procedures and referred procedures coming from other institutions. The hospital and the clinic protocol for screening of patients must be strictly adhered to at all times. And upon triaging, the patient or the person will be classified as indicated by the Department of Health. A health declaration card or a health checklist or an equivalent institution-based form should be filled out and signed in the triage or screening area, both by the patient and the patient companion before entering the institution premise. This should be filled up with, of course, with assistance and counter-checked by a triage physician or, of course, in the lack of a triage physician, a counterpart healthcare worker, like, for example, our nurse, for all persons who will be entering the hospital and clinic premise. So these are samples of health declaration cards set by the Bureau of Quarantine and the Bureau of Immigration. This is a sample health declaration form and triage protocol used internationally by some other countries. This is a patient sample of patient demographic declaration and consent form that's been implemented by the CTMRI Society of the Philippines and was upheld by the Philippine College of Radiology. This is actually already in downloadable form, and each of you can actually be able to have a copy of this and probably use this or even modify this according to what your institution might be needing. So after triaging of patients, it's either the patient or the companion will have a possible history of travel or exposure, will be classified either as suspect or probable or even a confirmed case of COVID-19. And this patient and companion should be advised and managed according to DOH guidelines and policy of the hospital. But incoming patients or companion upon passing the triage can proceed to the Department of Radiology, the lobby, or the examination areas. It should be said that institution can have the option of actually doing their procedures outside the hospital premise through a dedicated examination room, provided, of course, that the formation and utilization of the examination room, probably your mobile x-rays or your portable x-rays, strictly, of course, follows the guidelines set by the DOH and the Food and Drug Administration, particularly the Center for Device Regulation and Radiation Health and Research. Inpatient procedures will be done according to the patient classification. All patients will undergo examination, and of course, the patient companion and the accompanying healthcare worker will be wearing a surgical mask or any improvised mask. All patients and companions shall present this health declaration card or health checklist or the equivalent institution-based form, as well as the physician's request. It can be, of course, the physical request form that was given by the physician, or because telemedicine is currently very famous at this point in time, it can be a printed request form in case of telemedicine to the staff prior to attending to their needs. Of course, you can enforce a no health declaration card and physician's request, no service and policy. This is the protocol that was given and the workflow that was given to us initially in the initial part of May of 2020, and this will be continuously evolving. I will be going through run through to all of this because I think Dr. Ramayla has already extensively discussed how we will be doing this on a step-by-step basis. For X-ray and ultrasound, you can either have a portable or mobile machine dedicated to the isolation area if feasible, and or either dedicated one room in the department if feasible in handling suspect, probable, or confirmed COVID-19 patients. In portable machines, the ER or the ward should inform the radiology department, and the request forms must be filled out in the originating department complete with all the details of the patient, of course, including the history and the clinical impression. The exposed staff should be donning a PPE in an interim area or just before entering the isolation area. In performing the procedure, it should be noted that the radiology staff should practice universal infection control standard, both for contact and droplet precaution and as well as airborne precaution. And the assisting person in the procedure, either the resident, the ER doctor or nurse, the ward nurse or staff should be, of course, still in full PPE. And now the radiologist staff will perform the procedure. Likewise, if you have a dedicated one room only in the department because you lack a portable one, and with the use of our installed CT and MRI within the department, the same procedure should be done. The ER or the ward should inform the department before bringing in the patient so that we can actually schedule everything. Can actually dedicate a certain schedule, especially for these kinds of patients, so that you will be doing the infection control and the disinfection process adequately. The request forms must be filled out in the originating department complete with the details of the patient. Again, the staff should be preparing the unit, making sure that the waiting and examination areas are patient-free to prevent unnecessary exposure. And the staff should be donning a PPE and prepare the room for examination. Likewise, in performing the procedure, all should practice universal infection control standard, both for contact and droplet precaution. And both the accompanying companion will be transporting and accompanying the patient should be donning a full PPE. The radiology staff will now perform the procedure, and then the patient will be brought back to the ER, the ward, or the isolation area. Again, the disinfection and sanitation of the unit and equipment after procedure was extensively reported by Dr. Amila. Proper disposal of the PPE used in yellow bags should be done, or in a very adequate disinfection of the improvised PPEs should be done in areas of inavailability. Likewise, proper infection control, especially for hand washing, should be done by the staff. And then both the images and the result should be relayed by the reading staff through telecon, through a PAC system, or other means of observing social distancing. But at this point in time, it was very important that somehow our own department should have had a PAC systems to be able to follow the rules and regulations of the National Privacy Commission, especially in handling our images and data. How about in handling patients and non-COVID patients, both for OPD and inpatients? So for all our procedures that we're doing for outpatient purposes, the patient and the patient companion, again, must be triaged in front of the clinic or the hospital. A health declaration card should be made and should be accomplished and should be submitted. And all patients and patient companions should be wearing a face mask before entering the hospital premise. Likewise, for inpatient, the ER, the ward should inform the radiology department before bringing in the patient, and the request forms must be filled out in the originating department. Again, the radiology staff will receive the patient and the request form, observing proper social distancing. The patient company should stay in the waiting area with proper social distancing unless necessary, of course, in assisting. The staff would prepare the unit, making sure that the waiting and the examination areas have been properly disinfected as per hospital directive to prevent unnecessary exposure, and the post staff should don proper protection. It's either recommended or a graded PPE or an improvised but full PPE. Again, on the performance of the procedure, we will practice universal infection control standard, both in contact and droplet precaution and an airborne precaution for some procedures. And then all the accompanying persons with the patient should be in PPE or improvised but full PPE to transport and accompany the patient. After the performance, again, of the procedure, disinfection and sanitation of the unit and equipment should be done. Proper disposal of the PPEs used in yellow bags should be done, or adequate disinfection of the improvised PPEs in areas of inavailability, and proper infection control like hand washing after should be done by the staff. And then we'll go for the relaying of the information and the data. In general, patient and the patient companion and even the healthcare worker shall observe proper social distancing. So this is a minimum of 2-meter distance or 6 feet from one person within the department lobby or the reception area. It should be observed that the department should only accept patients within its capacity while observing proper social distancing and appropriate patient flow within the department. This will be varied in different institutions, and you yourself, of course, will be all knowledgeable in how to be handling this, of course, in observing proper rules and regulations. The strict social distancing must also be observed before and after the performance of the patient's procedure. Only one patient or patient companion or healthcare worker, if just needed, will be admitted to the examination room at a time. No other patient should be within the examination areas or adjacent corridor or lobby or space at any time. Our rad techs must be decked to render the service except those who are pregnant or the immunocompromised. All must do diligent disinfection measures, particularly hand washing and use of at least 70% alcohol or alcohol-based products, any liquid disinfectants, or soaps and wipes before and after rendering service to the patient and visitors. All patients, visitors, doctors, and hospital staff must be given free alcohol or disinfectant liquid or wipes to be applied on their hands and exposed body parts at the reception area and before entering the examination room prior to the start of any transaction, may it be a query, receiving of request, registration, or even the performance, of course, of the examination and then the claiming of results. Again, all the staff members must wear full personal protective equipment or the appropriate modification of this, which includes a cap and a mask, a face shield, an eye area protection like your goggles, a protective outfit or gown, gloves, a close appropriate footwear and covering. It can be implemented in your institution to have a no procedure policy if this is not given to your department. Each staff should be provided one surgical mask for entire shift or duty. There has been an ongoing debate whether healthcare workers should just be given a surgical mask because recent evidence and recent guidance that was set out by the World Health Organization and by the CDC just last week says that all healthcare workers should actually be in medically graded masks like your N95s or a modification of the China standard, which is the KN95s. Gloves, hands, and exposed body parts, including goggles and face shields, should be always sanitized with alcohol or disinfection liquids or wipes provided by the hospital after every patient. And of course, as mentioned, the mask, the gown, and the gloves may be replaced when necessary. In times of pandemic, we know that panic can always occur, especially even with us. So hoarding, theft, and wastage of such supplies shall be punishable according to hospital policies. So the standard PPE usually includes your surgical cap, goggles, your surgical mask, the gown with double gloves, and your foot covering. In a full PPE, this can actually be changed to a medically graded mask and with the use also of a face shield. While enhanced PPE is what's being used, of course, if you're treating your COVID positive patients, can be replaced by a hazmat type of PPE together with an adequate and medically graded respirator. Protective sheet or disposable covering the machines or cassette is highly recommended or can be mandatory and should be discarded or disinfected for every patient accordingly, as we have seen in the videos of Dr. Makababad. You can also, of course, sanitation of all the workspaces, tables, surfaces, and frequently touched areas every 6 hours is advisable with disinfectant supplied by the hospital. As a recommended disinfectant like your 70% alcohol or alcohol-based products, or a 5.25% sodium hypochlorite with a 1.49 dilution. This is just like sample, mixing 10 ml of bleach with half a liter of water as per DOH recommendation. How about the patient flow and handling for suspect, probable, or even confirmed COVID-19 cases? As I've mentioned, only portable X-ray ultrasound, if ordered, shall be done at such patients at the designated room in the department, in the isolation area or ward. Of course, the department head, your director, or medical director may allow a dedicated portable machine or ultrasound to the isolation room or ward if such facilities are available and without compromise of operations of the unit. Again, all staff members should be provided and with with full personal PPE or appropriate modification of this, as mentioned. And such implements shall be disposed properly according to the guidelines set by the Infection Control Committee. The assigned staff should serve the patient or patient must disinfect by either hand washing or even bathing or even use of alcohol disinfectant fluid before returning to the department or even coming in contact with other non-isolation staff. Your equipment must be completely disinfected with either soap or water, alcohol, a disinfectant liquid or wipes, of course, according to the instructions given to you by the manufacturer of the machine after every use, especially for those machines who are under warranty, so that you won't be forfeiting the warranty that's being given to you by the provider. Your disposable covers or linens are highly recommended on cassettes and examination beds to prevent contamination. Again, the CT scan and the MRI machines, especially the gantry area, the console area, workstation, and examination rooms, or the X-ray and ultrasound machines and examination rooms. In the absence of a dedicated portable X-ray and ultrasound machine, must be completely disinfected after at the end of the procedure, after every procedure. Again, as I've mentioned, disinfection of the machine and rooms must be done using appropriate disinfectant mandated by your institution, appropriate disinfectant recommended by the manufacturer, or a 5.25% sodium hypochlorite with the following dilution. Another high hour of drying up must be implemented. It has been mentioned that air conditioning system or indirect respining should be turned off during the disinfection and drying process. Procedures may only be done only during a designated schedule by the department or after all procedure or scheduled patients for the day have been served, unless with emergent indication or emergency situation. This can be handled, of course, with the coordination with the department and with the meeting of your chairman or probably of the consultants on how to handle the scheduling of the patients. Additional principles in handling patients within the Department of Radiation Oncology is a must and is actually a little different, especially, of course, in handling our diagnostic procedure patients. Radiation treatment must not be interrupted and as much as possible due to high mortality risk from cancer. Your suspect, your probable, or even confirmed COVID-19 patient should stop or interrupt treatment immediately until medically cleared to protect other patients undergoing treatment and the medical staff. For asymptomatic patients with no history of exposure, radiation treatment may be continued and treated toward the end of the shift. But in order for us not to jeopardize the treatment outcomes, radiotherapy must be continuously done on a daily basis, especially for patients undergoing definitive treatment. Of course, including your emergency cases, like your superior vena cava syndrome, your spinal cord compression syndrome because of your spinal metastasis, or those who have active bleeding, for palliative intent or other alternative therapies, and of course for adjuvant therapy. In here, the attending radiation oncologist should decide whether to defer or to delay the treatment, depending on the risk of recurrence with little or no survival benefit. Shifting to a hypofractionated regimen is also recommended if patient and treatment site appropriate. Of course, due to the nature of the treatment is delivered as well. All efforts must be made to shorten, of course, the hospital time and the number of hospital visits. We should always separate patients undergoing concurrent chemo, RT, or immunosuppressive therapies from those who are not by assigning an isolation room, because we all know these are immunocompromised patients. A structured schedule will be continuously implemented in the Department of Radiation Oncology, which includes shortened clinic hours for physicians, limitation of checkup only to patients with ongoing treatment, no follow-up for patients not undergoing treatment unless, of course, there's a pressing concern. But in case there's a pressing concern, of course, this can be done on an appointment basis or even a phone or conference calls instead of a face-to-face contact or consult. And patients should be instructed to go straight home after treatment. One very important part is the disposition of our staff who rendered service to suspect, probable, or even confirmed COVID-19 cases. This is still quite a very controversial thing, as the same topic for all those of other employees who are going back not to work. All staff members must be vigilant and observe themselves for symptoms of the disease for 14 days, or the number of days deemed appropriate by the institution. It's been mentioned that for a lot of current studies, the earliest virus shedding can be as early as 2 to 3 days from the onset of symptoms, to even from 5 days to 31 days after exposure. So the quarantine period of 14 days is actually the average time, or the majority of this is the manifestation for a majority of patients, wherein they usually undergo a 14-day period. That's why we also observe the 14-day quarantine. But some of patients can actually extend beyond 31 days, as we have seen in other institutions, especially for COVID centers. All staff members with exposure confirmed to COVID-19 case should undergo 14 days of isolation or quarantine as mandated by the Department of Health. A PCR testing, either with an ancillary lateral antibody testing, shall be done on all staff members with the following criteria. For all asymptomatic but with very relevant history of travel or exposure, hopefully at this time this is not already much applicable. Mild to moderate symptoms and relevant history of travel or exposure. Those who have mild symptoms but with relevant history of travel exposure and in the vulnerable conditions, but with those with severe or critical symptoms and relevant history of travel exposure. In general, it has been mentioned that for all symptomatic staff members with or without exposure to confirmed COVID-19 case, they should undergo a 14-day of isolation and quarantine as mandated by the Department of Health and should do a personal contact tracing. If symptoms should progress, the staff must go to the hospital triage area or nearest medical facility of choice for possible admission and, of course, medical management. Such staff may only report for work when symptom and disease-free, has served full quarantine period of 14 days, and underwent another testing based on the appropriateness of the disease state, either a repeat RT-PCR or lateral or your antibody testing with confirmatory PCR. So this is the Argyle Reserve for close management and testing for those who have close contact with confirmed COVID-19 cases as released by DOH last May 11 of 2020. So for all those who have exposed to confirmed COVID-19 cases, for asymptomatic non-health workers, you should undergo a 14-day strict home quarantine, monitor for development of signs or symptoms until the end of the quarantine, and at this time, no laboratory or confirmatory testing is mandated. For asymptomatic health workers with low risk exposure, the worker may still report to work but shall undergo self-reporting for the next 14 days, and no laboratory confirmatory testing can also be done. But for healthcare workers with high risk exposure, even asymptomatic, shall undergo a 14-day strict home quarantine, a laboratory confirmatory testing, and monitoring of development of symptoms. But for those who had confirmed exposure and who are also symptomatic patients, you should undergo a health facility isolation and undergo laboratory confirmatory testing. But for those who did not fit suspect COVID-19 case definition, still an undergo in the strict home quarantine should be done, monitor for the development of symptoms, and no laboratory confirmatory testing is actually mandated. That's my last slide. Again, thank you for your attention.
Thank you very much, Dr. James, for that wonderful lecture. Dr. Gabby? Dr. Gabby, are you still here? So now we're going to proceed with our question and answer section. So we have a few questions from our viewers. So I think some of them have been answered, but we will mention them so that everybody can also learn from the questions of the other people. So first question, are HEPA and UV filters helpful in the radiology department for additional protection? Dr. Myla or Dr. James can answer this question.
Yes, it helps in the air exchanges, but the filters have to be changed regularly, and it has to be placed near the patient.
Dr. James, any opinion about this?
Adding to Dr. Amaya, HEPA filters will actually be very helpful. But again, re-emphasizing what Dr. Amaya said, the changing of this HEPA filter should also be mandated. Because if you won't be changing this, of course, the radiologists and the staff will also be prone again for infection. But aside from the HEPA filter, I think what's more important is for us to be able to probably adjust our rooms or our examination rooms to a negative pressure system or even a unilateral flow air system, so that it will be very helpful. Probably adding an exhaust fan in the isolation room will be very helpful. Likewise, having windows will be very helpful as well. So as we know, HEPA filters are quite exorbitant, and not all institutions, especially small clinics, can be able to do this. I have a small clinic which is not able to buy a HEPA filter. So what we did was to do a unilaminar flow from the air conditioning unit to the radiologist, to the machine, and eventually the patient with an exhaust fan. Likewise, the adjacent reading area wherein you will be typing your result has another exhaust fan. And then we added a window that you can actually exhaust all the air after you did your procedure, and you can do the proper disinfection process after the shift.
Yeah, I think at the end of the day, we just need to research on what we are going to purchase, since these are not very cheap materials. So we need to know the advantages, disadvantages, and limitations of what we are purchasing. Now, next question. I use an elastomeric 3M 6000 respirator with disposable filters. Can I use this for all patients per day since I have a face shield? Can any of our speakers answer that?
In my lecture, I discussed there that we have downgraded our levels of PPEs. Okay, but it's not bad to overprotect yourself if you're afraid. Okay, but basically, our procedures are non-aerosol producing, so a simple surgical mask and a face shield will suffice, or if you have a N95, better.
Okay, thank you very much, Dr. Myla. Dr. James?
Actually, I think the 3M respirator types, no, especially the valve types, aside from actually making you look good, no, like Darth Vader, can actually be it's more of the, I think, the comfort of the radiologist. You have to realize sometimes you're doing procedures or you're wearing your mask for probably what 4, 5, 6 hours a day, and sometimes I think even for a personal experience, wearing a N95 mask will actually give you markings on your nose and even markings on your face and even wounds, no? And somehow the respiration process or the respiratory process for most radiologists is not really that nice, no, when you're using the usual mask. That's why these 3M respirators can actually be helpful if you are having some discomfort using the usual N95 mask. But they're actually varying. I think Dr. Mila can also attest to this. There are varying testimonies, no, on on the efficacy or the efficiency of using either a usual N95 mask or your 3M respirators. But most of the journals or most of the articles will say that there will be actually having the same. No? If you have, sabi nga ni Dr. Mala, if you have a properly fit N95 mask, the filtration process of that N95 mask will be the same with your 6,000 pesos 3M respirators. I think it boils down to the comfort of the radiologist. And number two, it's not only the wearing of the mask or the respirator that's very important. The disinfection process that follows that, I think, is also very much important.
And the filters have to be changed.
Yes, Doctora.
Maximum 40
And the
hours.
filters are also expensive.
Okay. So our next question is, what is the suggested PPE for performing fluoro procedures such as upper GI series and barium enema? Would you consider these as aerosolizing procedures? Dr. Myla, Dr. James?
Upper GI series is high risk. Upper GI series is high risk, barium enema low risk. It's like doing endoscopy and tracheostomy procedures for upper GI series.
So they will
And you
just
can
wear the...
actually,
Yes, Dr. Myla.
all procedures that involves nose and mouth are high risk.
Okay. Another question, I work in ultrasound. Do I have to use a coverall and don a gown for every patient?
Not if the patient is in the COVID ward or in the triage.
So we need to really
The
screen the
regular
patient.
OPDs.
Okay. So our next question, when we do portable ultrasound procedures, such as bedside, whole abdomen ultrasound, some patients are not compliant to wearing masks. How do we proceed?
Well, just protect yourself. We cannot force patients to wear masks, especially if they are not comfortable, especially if they are already having difficulty of breathing. Unless they are given oxygen, okay, they can have mask over the oxygen tubes.
Actually, I also do agree with Dr. Amela. If reverse isolation is not possible, I think the most important thing is for you to be able to protect yourself. So you should be wearing the full armamentarium, especially on the upper respiratory tract area. But if you have, of course, if you have a nasal cannula, mask is still mandated. And probably, I think the most important thing for us radiologists, and probably our ancillary staff, like the nurses, is for us to be able to explain the patient why we need to do it. Because most often than not, if we are able to explain to them why we have to let them wear a mask, I think they will be able to comply as well.
So we communicate with our patients. Okay.
Yes.
Next, if I wear the appropriate PPE like face shield, mask, and gloves, is there still a need to place a barrier between me and the patient?
Actually, that's a very controversial question. Because during the start of the pandemic, a lot of us have been actually using a lot of barriers when we're doing our ultrasound. So what I did was to actually consult the Philippine Society of Microbiological and Infectious Disease, no, particularly Dr. Mediodoro Sanyal regarding this matter. And as I've also emphasized by Dr. Maya earlier, we are not doing aerosolized procedure when we're doing ultrasound. So probably wearing the appropriate PPEs in your doing ultrasound will already protect us. And if we're wearing the full PPE, we're already actually at low risk already when it comes to doing these procedures. So these are non-aerosolized procedures, and if not, but according, as Dr. Ramayal has emphasized, if it will make you comfortable to actually do, I think the most important issue here is the proper disinfection process of these barriers for of course after the shift of that, because this virus can actually become fomites of the infection, as you've seen. For example, there's a study on the contact of the virus and how the virus stays. Like for example, but we know if it's just a paper, it can be just there for 3 hours. But mind you, if you have smooth surfaces like your plastics, like your leather, your virus can stay there for as much as 7 days if it's not properly disinfected. So we must be using these barriers with proper disinfection process.
Thank you for those answers. Now, next question is anyone or have you heard of patient isolation chamber for CT scan patients? This is the first time I've heard it.
Yes, yes, yes.
Actually,
But I've said earlier that we are going to procure CT scan maybe next quarter, but we have been planning the structure. No, I asked if they can do negative pressure. It's very difficult to have it with negative pressure. No, the whole the whole kisame yata, kailangan of the whole floor, kailangan babaguhin. So, meron lang kaming windows 6 feet above, no, and good exhaust system plus rooms for donning and doffing na through and through from outside to inside the CT scan.
So we really need to talk to our different sections, including engineering, biomed, and infectious section, right? Okay, next question. For doing outpatient ultrasound procedures, will a long coat, surgical mask, and gloves suffice? Or should doff the coat and don standard PPE? Or do I retain the coat and add standard PPE?
Hindi ka ba nainitan dun?
So I think it's either the PPE or without the white coat, right?
Yes.
yes.
Okay. There are also studies that say that the white coat sometimes add infection. Is it correct, Dr. James?
Yes, actually, this rate can be a format for as much as possible. Di ba sabi nga, when they're actually giving all these advices, we have to lessen anything that's attached to us. No, sad for our female radiologists, makeup should actually be going for now. You should be going for away for your with jewelries and other ancillary stuff. So the lesser it is that's attached to you, the lesser also will be the format for also for infection. Again, I can think with that condition, especially when you're doing an outpatient ultrasound, especially in the different clinics, I think what's more important, you can actually wear the same protective. You have your own gown. What's more important, I think, is the changing also of the gloves. No, you have to change the use of the. That's why we have a double glove system. You have an inner and outer gloves. You have to change the outer gloves after you have disinfected your area. You have to change to another gloves before you do another patient. Now that this, I think what's more important also for us, since there's also patient contact with this, as we had mentioned, it's contact precaution, is to probably have adjustment on the linens, no, of the patient. I know probably having to change the linens for every patient must be expensive, but there are a lot already of very cheap what you call this disposable linens, no, and even biodegradable that can be bought in the market, and you can change this for every patient.
Okay,
But
thank
if
you,
you don't have linens,
Yes.
if you don't have linens enough to do the changing of the linens every after patient, if your bed is leather, leave it as is and disinfect every after patient.
Okay, so we have two more questions. Is reusing N95 or KN95 masks allowed? Or how do you reuse them? Or what do you do to disinfect?
Actually, for the N95s or for KN95s, it's allowed no to be reused. But you have to do the proper disinfection process. It had been mentioned in a certain journal in UK that you can actually reuse an N95 mask up to at most 3 times. Dr. Ramayla, correct me if I'm wrong, up to 3 times, provided that you actually disinfect this either with a UV light system or a vaporized hydrogen peroxide.
No, no, no,
But
no, 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 no. Do not disinfect your N95s. What
okay,
we do, what is advised now, no, you assign five
okay.
N95s to each staff. Okay, you use the N95 on the first day, your first N95 on the first day. Okay, and then after using that, you isolate that N95, put it in a paper bag, label it, okay, and then keep it safe. Okay, tapos on the second day, you use your second N95 and so on. Okay, so the N95 are rotated
So for it's a cycle
for
for a week, yes.
for a week.
Yes, that's what I hear most frequently. You allot one mask per day and then rotate that set of masks regularly.
And you can use it 5 times.
Okay. Last question is, I understand that protocol is institutional. This is, I think, Dr. James or Dr. Myla's protocol. Our hospital infectious disease section said that there are no studies supporting triple gloving, and so also to save supplies. We were just asked to double glove and do proper hygiene. Do you have any suggested reasoning that they can give their infectious disease section to defend that statement that we need to triple gloved?
Actually, our triple gloves is a protocol for Ebola. For Ebola. And we had retraining probably 2 or 3 weeks ago. They recommend just one glove and do hand hygiene every day, just to protect yourself. So one glove now one pair of gloves can suffice.
Okay, thank you, Dr. Myla, for that. And I think we have already answered all of the questions by our members and trainees. So I would like to thank our speakers, Dr. Myla, Dr. James, okay? And I would like also to thank the staff of M. Menarini for making this event possible. So in behalf of the PCR, I would like to thank all of you for sharing your time in PCR Connect. Okay, our gratitude also goes to the staff of MNRINI for making this session possible. Dr. Gabby, thank you very much for also moderating this morning's session. And we hope to see you again in our future webinars. We have a lot of lectures in store for us. The on-demand version of this webinar will also be available soon in our PCR website, but first we have to increase the security of our PCR website. So these videos will also be in an on-demand version soon for our members and trainees. Any last words, Dr. James, Dr. Ramayla?
Dr. James, go first.
I think what's the more most important for our radiologists is to be able to make sure that you always assure your safety. You have to assert yourself as a radiologist, and you're an important person when it comes to the diagnostic process. And when it comes to supplies, I'm sure all of us have been quite having a problem, especially demanding things from our administration. I think the most important thing is to be able to, for the administration to provide for our safety, since we're a part of the team, part of the process of actually diagnosing and in the treatment of the patient.
I can only say, do not panic. Do not panic.
Okay,
Nagpapanik lahat eh.
That is short and concise. Ma'am Emmy, are you there? Ma'am Emmy, any words from Menarini?
Dr. Imar and the speakers, thank you very much for a very extensive discussion. I'd like to pass the floor to Dr. Gabby for some announcements. Thank you very much, Dr. Imar. Dr.
Thank you, Doctor.
Gabby.
Thank you, Ma'am Emmy.
Yes, thank you to our two speakers, of course, Dr. Amaila as well as Dr. James. Dr. Imar, thank you also for moderating this morning's session. I'd like, before I formally close the webinar, of course, I'd like to thank also the participative audience for all your questions. Please don't forget to fill up the feedback form right after the webinar is finished. And before I close, I'd also like to plug some of our upcoming webinars. So we will be having a webinar on acute kidney injury, complications in the cardiac cath lab, to be presented by Dr. Arnold Seto. So there will be 2 runs for this. The first run would be June 25 on Thursday at 10 a.m. Manila time. And the second run would be on June 26 on Friday at 1 p.m. Manila time. So all of you who are interested in attending this, acute kidney injury, complications in the cardiac cath lab. Now, our second webinar that is upcoming, we have our usual Angina Academy. So our Angina Academy topic would be the impact of COVID-19 and the ischemia trial in the management of chronic stable angina. So for this, we have invited a UK-based speaker. We have Professor Peter Collins, a professor of the clinical cardiology of the Imperial College of London and Royal Brompton Hospital in London, UK. And this will be moderated by one of our local speakers, Dr. Rafael Castillo. So for that, thank you again to the Philippine College of Radiology and as well as to our speakers and moderator for being able to discuss and moderate quickly this morning's webinar. So once again, I'd like to wish everybody a blessed Sunday ahead. Thank you and good morning.
Thank you, everybody. Thank you, Dr. Gabby, and thank you, M. Menarini.
So much, Dr. Imar, Dr. Amaila, and Dr. James. Congratulations.